put your hands together to thank them for being with us.
All right. Thank you very much. I appreciate all of you hanging in there and coming back this late in the afternoon for another breakout session. So how many of you are now scared to death to go have an MRI? Like me, right? Okay, so well, we've been learning a lot, and we promised in this conference we would be challenged. And yes, healthcare is challenging, and we want to share some thoughts with you with that. Why am I here? My background is commercial nuclear. These guys are healthcare, right? Why am I here? Well, does anybody remember a report written called "To Err is Human"? Back in 1998, it said that 98,000 people in the United States die every year as a result of the care they get in hospitals. And this was back in 98, 97, 98,000 people every year. Can you imagine that? Well, the numbers are much higher than that, much higher right now. 2013 study said it was anywhere between 220 to 440,000 people every year go to the hospital for care and end up with something that ends up killing them, right? So we really need to know a couple of things. As healthcare providers, we need to know what to do to improve. And as healthcare consumers, that's many of us, right? Most of us out here, we also need to know what to do. So that's kind of what we're going to be here for in this general session. And then right after this general session, we have a breakout to continue. So please, if you're interested in knowing what we can do to improve ourselves and improve our abilities to be safe in healthcare that we receive, then by all means, join us for the breakout as well. Now, one thing you can do to help all of us is continue to smile and show us that you're awake and alert and engaged and participating with us. My name is Ray Gonzalez. I have John Sims here, who's going to go next, and Gabriel Gonzalez right here as well. And so I want to go ahead and share a couple things here on the slides. And let me just turn this on. All right, there's our pictures. If you want to know more about us and our bios are out there available for you, right? So that's there. We are here. And we're going to cover 4 separate objectives. And I don't even want to take time going through them because we'll look at each one of them. We will hit each one of them one at a time as we go. So really at this point, I'm going to turn it over to John, who's going to lead us off. Thank you.
All right. Thank you very much. Boy, everybody's been talking about how this thing is really sensitive, and it is. Thank you, Ray, and thank you, Gabriel, for talking about this, this thing called healthcare. As Ray mentioned, I'm John Sims. My background is healthcare. I've been in healthcare for about a quarter of a century, most of that time spent in hospitals. Currently, I direct a patient safety division called Safer Care Texas at the University of North Texas Health Science Center. And I am privileged to do that. Let me ask y'all something though. Y'all have heard the stories today. What do y'all think about Rory, the little boy who was misdiagnosed and passed away? And then Michael earlier, who died tragically from the MRI. And y'all can speak up. Speak up. What do y'all think about that? Is that it is scary, isn't it? And the sad thing about that is that doesn't happen every day. It doesn't happen every day. But healthcare is different in that there's a myriad of different, there's a very complex system. So there's a myriad of complex processes and several people to talk to get a procedure done, or just a simple task. There's so many people involved that things are going to fall through the cracks. How many of you, by a show of hands, have accessed healthcare in the last 12 months? Okay, that's almost everybody. How about the last 6 months? Okay. Now, I've talked to a few of y'all, okay, during this conference. How many have been the victim of a medical error? How about somebody that you know might have had a medical error? Okay, look around the room. We've got a pretty good sample size of America right now, right? And there's several people who have been victims of medical errors, and we need to fix that. I have to tell you, this is my first time being at this conference, and I am elated. Why? Because being in for working with Safer Care Texas at the university, our mission is to challenge traditional thinking to eliminate preventable harm. And we have a lot of work to do in that space, right? Ray mentioned to err is human back in 1999. 44 to 99,000 people at that time were estimated to have died from medical errors. Some of our speakers have correctly said that those the new numbers are more between 220 to 440,000. Does that mean we're getting worse? Are we measuring better? What are we doing? Those aren't good numbers. We should be going down, not up. And the reason I'm excited about being here is I'm here with industries who are all focused on improving public safety. And in my view, you all have done much better than we are. You've already established a culture. You've already established all of those fail-safe things that we have yet to realize in healthcare. And why is that? I will tell you that I think it's because we have a mindset of profits over people. Gentleman I met at the conference today, who I still need to reconnect with, he said that it's productivity over prevention. And I think that's a really good way to explain healthcare. So let's jump in here. Oh, I would be remiss to not share my wonderful team, okay? So Safer Care Texas team is the clinical, patient, and safety quality experts. Bobby Bratton, Doctors Tracy Chambley, Teresa Wagner, and Kate Taylor, who were here today, but they had to take an earlier flight, so they're not here for this presentation. And then research and biostats. We have Doctors Beeson, Leslie Alsop, who's right here in the front row. Raise your hand, Leslie. Thank you for being here. And then Dr. Basu and Dr. Ariel. And then those, I love this because community outreach and advocacy, they are focused on prevention at the community level, led by Leanne Cunningham, Rachel Swink, Rebecca Green, and Julia, I was going to say Julia Robert, Lord have mercy. So let's jump in here and talk about why I believe that it's productivity, that healthcare's main focus is productivity over prevention. So if you can see this graph, the US is right over here. And what this shows is how much healthcare expenditures, how much we're spending. And this here is the GDP. The US is spending, this was in 2019, 16.8% of the GDP on healthcare expenditures, okay? This here shows what, this is high performance, this is low performance. So the US is spending more and their performance is lower than the rest of these high income industries. What does that tell you? Well, it says a few things. How many of you have had a procedure, or you've had a delay in maybe even just getting a medication, right? Did anybody ever ask you, hey, you need a pre-auth for that? Have you ever heard that? So you might be surprised to know, and this is just private industry, in the private insurance industry, more than twice of the expenditures are spent on managing insurance claims and pre-authorizations than the overhead that it takes to run those different industries. That's insane. I liken that to like a home warranty company. If you've ever had a home warranty company, I have, and they almost seemed like they didn't want to cover what I was asking them to cover, right? They were trying to figure out what not to cover. And we've got to change that. We've got to change that mindset, because patients are dying as a result, or they're having horrible, poor qualities of life. And I want to correct my colleague Ray on one thing. You all in the room are not healthcare consumers. You're not healthcare clients. You're healthcare partners. Let that sink in. The days of people, of healthcare providers coming in and saying, this is what you need to do, you have an equitable contribution to your own treatment. And guess what? Let me ask y'all this. How many in the room have a PhD? Raise them up high. Be proud. It's okay. It's really okay. I'm going to tell you that everybody in this room has a PhD on their own bodies. Don't forget that. When somebody asks you about your symptoms and how you, they need to listen to you. Even if you can't articulate it in medical terms, you need to listen to, or providers need to listen to you because you're an expert when it comes to your body. How safe is healthcare? So this slide on the bottom there, number of encounters before the first death, okay? And then total number of deaths. You see where healthcare is. Healthcare is up here at the very top, and kind of ran out of room on this. Because remember I was telling you 220 to 440,000. And we're what at about 350. So number of encounters for the first death is 350 in healthcare. Think about that. How many people get on an airplane? Okay, that's a big deal. Now look at, we have a lot of nuclear power experts here. Look where they're at. They're at 10 million before they see their first death. And even then, look how many they have. They're in the 15 to 20 range. What are they doing differently than healthcare? And how does that make you feel when you have to access healthcare? Because all of us have to access healthcare, right? All of us we need to stay well. And when we get sick, we need to be treated. If we have an accident, when we have an injury, we need to be treated for that. And we don't need to fear death as a result. So what is there? There's drivers of healthcare right now. There is a lack of a culture of, boy, there goes that trigger finger there. A culture of safety is a strategic imperative. What I mean by that is that starts from the top leadership down. Because if the top leadership has to embrace that culture of safety, if you start with everybody that's doing the work, that's great. They'll get it, but it will quickly die because it's not a culture that's well-rounded throughout the organization. Second thing is we need an environment that empowers psychological safety. Psychological safety means, hey, I made a mistake, and not being fearful that you're going to be reprimanded in some way because of that. Because as you all have already mastered, and already humans are very fallible and they will make mistakes. So trying to re-engineer humans is a fruitless initiative. A just culture. Healthcare, we talk about a just culture, but in this conference, I've heard everybody say it's not just about talking about it, but it's applying a just culture. So a just culture is a learning culture where you don't focus on the outcome, no matter how egregious it is, you focus on the behaviors and the processes in place that made that horrible outcome possible. Why? So that you can change that system and that process to prevent that error from repeating, hence improving patient safety. The last thing we need to apply, I'm going to use that word again, apply high reliability principles. You all, again, y'all know what those are. Deference to expertise, preoccupation with failure, sensitivity to operations, a commitment to resilience. I missed one. Which one did I miss, y'all? Speak up.
She said mindfulness.
Mindfulness, I don't think that's deference to expertise. Thank you. So what are our solutions? Well, they're just the opposite of what we're lacking. We need to transform to a culture of safety. We need to foster psychological safety, establish a just culture, and apply those high reliability organization principles. So right now, I don't know if y'all can see this, but I heard one question in this conference: what's happening when nothing's happening? Well, that's where we are here with being unmindful. right? That means we don't even know what we don't know. Well, now we do know when we get to this reactive, that's what we saw in that Redondavant case. There was a horrible outcome. They reacted and they punished. That won't improve patient safety. Now, when you move up here and you get to systematic, now we have systems in place. We're making some headway until we get to proactive, preoccupation with failure, and then we get to generative, where safety, where a lot of your industries are right now, is something we do every day. It's natural, it's muscle memory. And that's where we need to get to with healthcare. I'm going to give it over to Gabriel here, and he's going to tell you 3 patient stories. But I want to leave you with this quote: all men make mistakes, but a good man yields when he knows his course is wrong and repairs the evil. The only crime is pride. Thank you. Gabriel?
All right. Hello, everyone. I'm here today to share some stories from the front lines of healthcare. I have experience in mostly emergency care from the military up to what I do now, which is helicopter EMS. But I started my nursing career in the emergency department. So the stories I'm going to be sharing today, the first 2 are going to be related to experiences that happened in emergency departments that I worked for. So the first one.
Sorry. There we go.
All right. So before I get started on this first story here, I want y'all to try and recognize what sort of local factors or error precursors led to this mistake. And I want you to also ask yourself, is this the type of environment that I want my nurse that's taking care of me working in? Because I can tell you right now, and one of the reasons why I'm here is because the environment, I hate to say it, it's grim, it's bad, and it's gotten worse since the pandemic started. So the first story here today is an event that happened in a level 1 trauma center at one of the busiest emergency departments in the country. It's in like the top 30 busiest as far as patient encounters go for the emergency department. So anywhere from 350 to 500 patients a day, average of 7 to 10 hour wait times. Sometimes the patients and families would be so disillusioned with how long they're waiting, they'd order pizza. Like it's bad. The staff, they are chronically understaffed, the nurses. It is common to never get a break. You don't even ask for it. It's like, why, nobody's going to come and relieve you. Everyone eats at the nurse's station, even though we're not supposed to. You might eat some nuts or have some water or something like that, and that's all you got sustaining you throughout the day. And also, there's a bit of a toxic culture among, I would say, the majority of the staff and some of the management. So this is a culture where you don't come forward with your mistakes and you don't ask for help because it's seen as a sign of weakness. So this nurse, he's got a full patient load on a busy Monday night. The emergency waiting room is packed, and he's got all this pressure to take care of his very high acuity patients, okay? One of his patients receives an order from a doctor for a medicine called levetiracetam, which I have a hard time saying it. Everyone has a hard time saying it. So people refer to it by its trade name of Keppra, because it's way easier to say. All right, and you can see it, you'll notice that this can cause issues, you know, using the generic and trade names interchangeably. And you might notice that from a very famous case that he mentioned, the Redondavant case. So he looks at the order. This is a medication that we give all the time for patients that are having seizures. So it is a frequently performed task. Like every emergency nurse there has done it 100 times. So he goes to the medication room and goes to the dispensing machine, which we call a Pyxis machine, and he types in KE. And the first thing that pops up is a medication called ketamine, but he doesn't realize that the Keppra is under its generic name. So he doesn't even think twice about it. He presses the first thing that pops up and pulls 2 bottles of ketamine. Does anybody know what ketamine is here? Can anyone tell me? Yeah. So that's the majority of people know it from their cat probably got it when they went to the vet, or or they know somebody that, you know, partied a lot in high school or in college and went to clubs and took ketamine. So it's got a bit of stigma around it, but it is an incredible medication that I use a lot in my current practice. Okay. So he pulled two bottles. They're 500 milligrams a piece. And this should have been a moment where he was like, well, this is different. Like usually the Keppra is pre-mixed in a bag and I don't have to mix it myself to administer it. But he doesn't ask any questions. He pulls up the 2 bottles worth of ketamine and injects it into a bag of saline to give IV to his patient. So he prepares it all. He even tapes the bottles of ketamine to the IV bag so he can scan it at the bedside. So he goes to the bedside, goes onto the computer, opens up the medication administration record like he's supposed to, and then he uses a barcode scanner. Have you guys seen that, where the nurse will scan your wristband to verify who you are, but then they also scan the medication to make sure that the order is in the computer, okay? So he scans the bottle of ketamine and an alert pops up. It's like, this medication was not ordered for this patient. Well, we have the ability to override that. So he just goes ahead. He doesn't take a hard stop and goes, hey, like maybe I should get an extra set of eyes on this, because like I said, the toxic culture, it would be seen as a sign of weakness. Everyone's just as busy as he is. He is a high functioning ER nurse. He's supposed to handle it himself, right? So he goes ahead and overrides it and then gives 1 gram of ketamine in 15 minutes to this patient. So this basically, you know, mentally put this patient on another planet. Like, I'm sure like he was just like out of his mind, you know, but he was later found in a deep state of sedation, which almost led to him getting intubated. So you can see how, like, in an intubation, if you guys don't know, is when they put a tube into your airway to help secure it so you can continue to live and breathe, okay? When you can't control your airway yourself. So that event happened, and there was no follow-up on what caused the mistake. Everyone just ostracized him, and eventually, like, he couldn't handle everyone kind of looking down on him and stuff, and he was just forced out of the emergency department. He still works as a nurse today, but he just doesn't work in the emergency department anymore. All right, next story. It's a very personal one because I'm the nurse that made this mistake, and this is the first time I'm telling this to an audience, so like, please bear with me because I was devastated when I made this mistake. I just couldn't believe that I'd done it. So I want you to think about the beginning of the pandemic and those news stories you saw of the poor nurses in New York City just being absolutely overwhelmed. They were short-staffed and they had more patients than they could possibly handle at an acuity level that they'd never seen before. They didn't even know the doctors, the intensivists didn't even know how to treat these patients, okay? So I saw that was going on, and I was in the middle of travel assignments. So I was like, you know, I got to go up there and help. So I got a contract. I went up to Brooklyn, went to a small community hospital that's very underserved. So their resources were very strapped, like out-of-date equipment, very little supplies, no computers at the bedside. The nurses, a few days before I arrived, the situation was so grim that every single bed in this tiny little ER that was probably about as big as this conference room, where the beds are separated only by curtains and there aren't individual rooms, they did not have anywhere to put the dead bodies. Like, they were stacking them in the hallway in body bags. Like, that's how grim the situation was, okay? So you have the staff there that is incredibly stressed out. They've experienced a severe amount of trauma and loss from the confusion of the beginning of the pandemic. And then to add on to that, the environment, everyone is wearing full PPE bunny suits like you see on TV. None of it fits right because it all came, you know, like secondhand from China back when nobody could get their hands on PPE, and none of it fit right and none of it really worked properly. It would fall apart. Also, there's a giant fan in the room trying to circulate the air because they still weren't sure if it was airborne, if it was droplet or what. So communication was incredibly difficult. You couldn't communicate. You could barely communicate verbally because of the N95. Then you add the fan, and then they add the ability, like you're wearing a hood and a face shield. You can't even like use nonverbal cues with people. Like it's hard to even read people. So my first night there, I'm getting shown around the emergency department by a preceptor, which is the training nurse. She's supposed to show me everything functions in this emergency department. And they were busy. And within 20 minutes of me getting shown around the emergency department, I get pulled for a cardiac arrest. This patient with COVID had stopped breathing, their heart stopped, and they needed help doing chest compressions. So I rotated with an intern physician for 2 hours. We rotated doing compressions in full PPE. And then we got this patient's heart back, and stabilized him enough to go to the ICU. So I helped transfer this guy up to the ICU. And then on the way back down, once we get there, it's 2 a.m. I'm sweaty, I'm tired. I haven't eaten or had a break or anything like that. And the preceptor is behind on her assignment that she had. So she was like, hey, see that patient over there? She just points at him and she goes, I need you to give insulin to this patient. He's got long-acting insulin and a sliding scale insulin dose, which I won't go in the weeds there, but some of you probably have family members or take insulin yourself. It's a very common medication to give, although it can be high risk because it is fatal in high doses. So I gather all the supplies, I gather the medication, and I start prepping the syringes. The preceptor stops me while I'm doing this, and this is a task that I've performed hundreds of times without any errors that I know of. And she's like, I don't want you to do it that way. I want you to draw one syringe at a time. And I'm like, okay, well, I'm a guest here and I'll just do it like she's asking me to do it. So I check the patient's blood sugar. I look at the sliding scale, and according to the sliding scale, it says that I need to give 1 unit of insulin, which is a tiny dose of insulin. And I pull what I think is 1 unit of insulin up in the syringe, and I ask my preceptor for a cross check. She's sitting at the computer trying to back chart the cardiac arrest event that we were just in. So she's busy. And I'm like, hey, can you please look at this? Because, I know that if I get this wrong, I could potentially hurt the patient. And she looks up at me, and I don't even know if it registered like what I was asking, but she goes, yeah, and just like waves her hand. But I didn't push to be like, hey, I need you to like really like look at this. And I go to the bedside where I said, like, there's no computers, there's no scanning or anything like that. And I give what I believe is 1 unit of insulin. I go back to where I was prepping my medications, and I noticed that in the discarded wrapper on the table and the syringe that I'm using to pull up the other dose of long-acting insulin, I've got the wrong syringe in my hand. I couldn't believe it. I was like, oh man, like, I hope I didn't use the wrong syringe for the first dose of insulin. So I look at the package, the empty package that I used, and it says TB syringe on it. They're dosed differently. The insulin syringe is dosed in units, and the TB syringe is dosed in mLs. And I gave 0.1 milliliters of insulin, which means that I gave 10 times the amount I was supposed to. I am so thankful, and I feel the patient was lucky and I was lucky that the sliding scale dose was so low, because if it was 5 units or 10 units, you can see how that gets exponentially worse, and I could have killed the patient. And it's incredibly hard to reverse that sort of thing. An insulin overdose, I've taken care of many insulin overdoses, and they're very hard to treat. So I immediately stop what I'm doing, and I fess up. I'm like, hey, look, I made this mistake. I'm 100% sure I made this mistake. Look at the wrappers here. Look at this. I don't know how this happened. Like, I'm really sorry. She's like, it's fine. We'll closely monitor the patient. So I had to do blood sugars every 30 minutes to make sure that I didn't crash the blood sugar, putting them into like a comatose state or anything like that, which pulled me away from my other patients, because I had to stop what I was doing every 30 minutes and check on this guy. And and then we told the doctor what happened. And luckily nothing happened. But you can see how all of these local factors and error precursors can lead to errors that seem inconsequential, right? But we need to learn from the inconsequential ones so we don't have an event like the Ron Devant case, which I'm going to go over here, kind of touch on here in a second. But after all of that happened, I went to where I got the supplies, and I noticed that mixed in that drawer, it was insulin syringes and TB syringes mixed in the same drawer. It was a landmine. I stepped on it. Like the things were mixed in there. I saw the yellow caps in the drawer. So I assumed that all of the yellow caps of the insulin needles, which is the signature of the insulin needles, I assumed that all of them were in there, and I grabbed two TB syringes instead. So I pulled all of the TB syringes out of that bin so nobody else would step on a landmine hurting a patient. All right. Next up, okay, so this is Charlene Murphy. This is the patient that was killed by the medication error that Rhonda Vaughn made, okay? So in the breakout section, we'll go into detail on what some of the error precursors were and how we could kind of mitigate those things. And you'll notice that in those stories that I just told, a lot of the exact same error precursors existed, okay? And I want you guys to think about, after hearing these stories, I'm like, do you want your nurses working in that condition? Do you want your families being taken care of in that condition? Also, what can healthcare workers do, and what can healthcare partners do? Healthcare workers, we can stop for a second when we realize we're in a situation where it is error likely, and take more time to complete tasks, ask for help. And also, if we do make a mistake, we need to tell people so people can learn from it. There needs to be a just culture environment in our hospitals. And then as a healthcare partner, we can all ask questions of our providers, have them explain. If you don't know what they mean when they use medical jargon, I used to interpret all the time. Residents would come in, they'd throw all this medical jargon out to these patients, and I would sit there and explain it to them. But a lot of times they were afraid to ask. So I'd be like, do you understand what he just told you? They'd be like, no, because most people just shake their heads, especially people where their English isn't their first language. They will just sit there and shake their head. And not every hospital has access to interpreting services 24/7. Right.
Okay. Oh, let's see. There we go. All right. So indulge this proud papa for a minute. Give him a hand for admitting that error. Huh? There's no other way we're going to learn until we start looking at these mistakes and start coming forward with it. So I'm going to cover the third objective, which was, hey, what other human performance elements hinder successful outcomes? All right. So in the stories you heard, you heard a lot of local factors and error precursors, right? Different types: local factors, error precursors, error traps. It's those conditions that surround us in the work environment that can drive error. All right. So, you've probably heard the term the Great Resignation. Have you heard that even during after COVID, right? What does that mean? What does that mean to you? The Great Resignation, what did that mean? It's, burnout. People are leaving. People are changing jobs. And all ages we're resigning to the fact that life is short and we're going to do something different, something I'm more passionate about. So a lot of things changed, right? How did that affect the healthcare industry? In nursing, last numbers I heard, currently we're at least 20% lower in nursing staff across the country than we were pre-COVID, right? And how many are we losing?
It's estimated that 500,000 nurses are going to quit this year.
This year. So low resources means what? It means high workloads, time pressure, right? These are just a couple of things. You heard other local factors. In the breakout session, we'll get into more specifics and things like that. But what are some other human nature drivers that will drive us to push forward? You heard that the healthcare industry is built on an endurance culture. You either cut the mustard or you're no good, right? You heard that, right? And so what does that mean in terms of peer pressure, right? Or just pride in what we do, because we're proud about the healthcare profession we've chosen. We want to get our jobs done. That literally goes for anyone. Everybody takes pride in what they do and want to be successful, want to get our jobs done, and so oftentimes we push ourselves sometimes into proceeding to the face of uncertainty, even when there's questions, even when there's things there. But here's the good news. When it comes to local factors and error precursors, they are manageable. To some extent, they are manageable. So let me ask you, how would you manage time pressure? It's the number one error precursor in any industry. How would you manage time pressure quickly? Come on. What do you think? Peer checks. What else? Okay, well, yeah, heck, if you had the resources, you could add more resources. That would be good. What do you think? How would you manage time pressure? If your staff, if your people are out there and you feel like they're under time pressure, what would you do? Give them more breaks, take 5. Basically, you would communicate really well, reinforce with them that we will take our time to get the job done correctly, but just stating things isn't really gonna take you there. Just making those statements isn't gonna be there. Here's planning and preparation is the number one way to manage time pressure. So this means that those pre-shift meetings and discussing what current workload is, what current staffing is, and what's projected or what could come our way, that planning and preparation can help you quite a bit, okay, in terms of managing. And that's in any industry, all right? Now let's just look at human nature drivers. Well, because of the peer pressure and other things like that, one of the biggest things we can do is train our people to be aware of those drivers: sign blindness, habituation, peer pressure, all those things we had listed previously. Make sure that we know that there are a lot of human pride, ego, those things that drive us to want to push forward. And when we feel like we're there, we know what to do. What have we heard in the past day or two about human performance tools and techniques? They're designed to do what? They're designed to slow us down, right? And to take time to get there. So being aware of those drivers that you might be in a sense of peer pressure or something like that, take your time, slow down. Let's make sure we get in the right mindset. There is something else that in terms of healthcare that they can do, healthcare professionals can do. They can learn more about what it means to stop the line. Okay, so what is stop the line? Well, in the Veterans Administration hospital system, they came out with this thing called Stop the Line. It's everyone's responsibility. In 2013, they came out with this campaign. I'll show you more in the breakout session if you want to come to our breakouts. And in 2013, they had a tremendous amount of success with Stop the Line. It sounded a whole lot like, what do we call it in our industries? What is it called? Stop work or stop work authority, right? It's exactly similar in the way they couched stop the line. If you see something wrong or different or whatever, stop the line, right? In 2013, they came out. That was 9 years ago. When I started asking this year in North Texas, in the community of healthcare that John and Gabriel and all of us live, I started asking about people, do you know what stop the line? A lot of healthcare workers didn't even know what that phrase, and it's been out there for 9 years. So stop the line never made it pervasively out throughout the healthcare industry. Does that make sense? Okay. Now, our final objective is to really talk about how do you transform any workplace safety culture in any high-risk industry. How do you get that culture shift? And I'll tell you, it's complicated, but we're going to talk about just 5 big picture items. There are a lot of little details in all 5 of these, but we're going to share these top 5. Number 1, the first thing you need to know is where you are. You need to conduct a baseline assessment, find out what your current performance is, find out what you are doing really well, right? We talked about that in this conference already. Find out where the success is so we can continue to repeat it and learn about it. But at the same time, identify those gaps where we can improve and do better. So baseline the performance, and then that way you'll be able to set up some structure. Number 2 would be then, as a result of that assessment, create an improvement plan, right? And that improvement plan is dynamic. It should be ever changing. It captures all of the things that you want to do to close the gaps and improve performance, okay? But it's dynamic and it should always be that way, okay? In addition to an improvement plan, no initiative can be successful unless you have a strong change management plan. And you don't know how many clients I have been to who create an initiative and they do not use a change management plan. But when I ask them, do you have a change management plan? They say, yes, we have a procedure for that, but they're not using it. they're not using it. In addition to a change management plan, a communication plan is also very important to have, right? You've probably heard the old saying, if you want to communicate effectively, do it 7 times, 7 different ways. And I'll tell you right now, it's probably 700 different ways. You have to have a very strong communication plan. Number 3.
So conduct an organizational training. Again, I mentioned this earlier. This starts from the executive leadership down. Excuse my bias for being a nurse, but you do need to listen, deference to expertise to them. And I guess they're speaking out. They are speaking out about the working conditions. Gabriel gave you a great glimpse of what the life of a nurse is like, right? Well, executive leadership doesn't always see that reality. And so the training needs to start with them. And then after that, training and competence demonstration application needs to occur on a consistent basis, not one and done and good luck, you got an RN and by your name and a pulse and get out there and be somebody. It doesn't work that way. Excuse me.
Right, exactly. Thank you, John. And so when we work with clients on shifting culture, when it comes to senior executive level management training, it is this big. When it comes to middle management training, down to the first line supervisors, it is this big. When it comes to the worker level training, it's about this big. That's how much roles and responsibilities and understanding at the higher levels need to know to drive successfully those initiatives moving forward. How about number 4, Gabriel?
Yeah, with number 4, so observation and feedback processes in the healthcare environment are virtually non-existent. You do have at some hospitals specialized teams that observe and kind of follow up on certain types of patients, like your stroke patients, your heart attacks, your trauma patients. They're more focused on, are they getting the right care and are certain metrics being met, and not at the end user, is everything being done properly, and can we tell the end user what they did right and what they did wrong? Very rarely does that happen. It is virtually non-existent.
Yeah, just to piggyback off of that. So all of those things are important because they're tied to reimbursement.
Money.
Quality indicators are at a certain level, then reimbursement is higher. We got to change that whole model from fee for service to value-based care. And we're a long ways from that. I am hearing it now, but we're a long ways from making that transition.
Okay, and number 5, the last thing I'll share with you here on this is you always have to follow up with some type of effectiveness review. You got to know, are you making any progress, right? And that's why I said that improvement plan needs to be dynamic, because your effectiveness review is going to tell you what's working and what's not. So those things that are not working, throw those out of your plan and adapt and change and make those changes to help you successfully continue on your journey for high reliability operations in your high reliability organization. Does that make sense? Is that fair? All right. All right. Well, look, we finished ahead of time. Woo-hoo. We're probably the only ones that did that, right?
Because of that work pressure and pace that we live through.
But we also wanted to make sure we open it up to questions. I mean, this is an opportunity to talk to these gentlemen about healthcare. Any questions, comments, snide remarks, we take them all.
You're psychologically safe to say whatever.
Jennifer has a question right here.
I used to work in healthcare safety a little bit. I did investigation. So thank you for sharing your story, by the way. I know it takes a lot of courage to talk to a group like that about something that happened to you. One thing that I was trying to institute within healthcare, it's been almost impossible to do, and I just wondered if you had an angle on this, is other industries do information sharing within the industry, right? Like aviation and the nuke industry. And I mean, they'll redact all the personal stuff out of it, but they'll say, hey, here's something where we had this drawer, we had these 2 types of syringes in it, and this is like an air trap, and you might have this at your hospital too. Here's what happened. Healthcare won't do that because of liability, right? But is there anything that we can do?
Absolutely. That's a great question. And I'll tell you, what it's called is a patient safety organization. Safer Care Texas right now is building a medical office patient safety organization, which there's very few in the country. But what is a patient safety organization? A patient safety organization is where in your industries, you have some means of reporting events, right? Well, we all have event reporting systems in hospitals. Once something goes to litigation, if a case goes to litigation, what do lawyers always tell you? Shut your mouth, don't say a word. Okay. Well, in a patient safety organization, members who are part of this, and it's very regulated. It's regulated by the Agency of Healthcare Research and Quality. We call that ARC. And they will list and recertify patient safety organizations. Those events, assuming they're not from reckless behavior, they're protected under something called patient safety work product. Because the ARC, Agency for Healthcare Research and Quality, they recognize that we've got to improve patient safety. We've got to talk about these events so that we can learn from them. So they're protected from that legal scrutiny to provide that platform for that discussion to take place. We learn the behaviors and prevent the errors from occurring again. Good question.
Of course, the downside is if we have that blame culture, then we squelch all that reporting.
Right.
Nobody wants to report anything, right? What else?
I kind of have a little bit of a unique perspective on patient safety, having worked in emergency departments, but then now currently working in helicopter EMS. And I'm not here representing any helicopter EMS companies. I'm here with Hope Consulting. I just like to throw that out there. But one of the things that helicopter EMS does great is that they have a very strong safety culture, because you can imagine that there's not only patient safety, there's aviation safety. So nurses and paramedics that are in that environment have to consider aviation safety and patient safety. So you see this like crossing of these two worlds, aviation that's very safe and has been working on safe culture for a long time, and medicine that's kind of behind the ball. So one of the great things about working in HIMSS, is what we call it, helicopter EMS, HIMSS for short, is that some of those aviation standards kind of bleed into the healthcare side of the house. So if I feel unsafe to fly, go on a mission or something like that, I can say, hey, 51%, like, I don't think that the weather is good enough. Like, I know that you're saying that you think we can squeak by, but like, I don't feel comfortable. Or I've been up we do 24-hour shifts. I've been up for 20 hours. I've done 5 calls. Like, I don't feel safe to do another one. I need time to sleep and eat. And they allow us to do that. So there's something that the hospitals could learn from aviation. And I really feel like that some of the providers and HIMSS can kind of help, because they get to see that how well aviation does things. Like, for example, my partner and I work with a paramedic. We do 24-hour shifts. The pilots do 12, because the FAA says they can only fly for work for a 12-hour shift, and they can actually only spend time in the air 8 hours. That's it, and then they're done. Like, if we go on a flight and they time out, they have to leave us, and they have to fly back to base, and the pilot that's relieving them has to come and pick us up. So just something to consider.
That sounds like an industry that prioritizes safety.
Absolutely.
Regardless of volume.
Yeah.
They're going to make sure that everything they're doing is safe.
My program director we're very high volume based. He's like, hey, I'll never push you to go on a flight. He's like, you guys do a great job, and I want y'all to stay safe first, because a helicopter crash with medical crew and a patient it makes national news. So
We have 1.5 minutes.
Well, the most succinct question and answer on history.
Most succinct.
Yeah, quick question. So the US performance versus spending, how do we compare with other countries as far as errors?
I didn't look at that data. The high performance and the low performance were quality indicators. I think errors may have been part of that. And then there was health equity, access to healthcare. Those were the metrics that they were determining when it came to were you high performing or low performing. Great question.
Yeah. Something to consider when we do make a healthcare error, it increased costs too, because now we're doing a bunch of things that we wouldn't have had to have done if we had gotten it right the first time. So that's something to consider as well. I'm not saying that it is the reason, one of the main reason why our healthcare is so expensive, but I can guarantee you it plays a part.
All right, that's it. We're back to you, Charles.
Hey, give these guys a hand. Thank you very much.